Okay, very fantastic. And now, for some dentists who begin to put implants and they fail more than 1% of implants.
J'ai tu veux pas le micro?
No, if we fail more than 1% of implants, there is a problem in the technique and all around your implant. I don't speak about the prosthetic act. The prosthetic act, we fail never. But when we fail an implant just before to put a prosthetic element, it seems we do a mistake. And for the doctor who came, there is some year, there are around the world always the same reason for failure of implantology. The first reason, but it's not written here, is to have a clinic correct done. What is a clinic correct done? It's not good to have in the walls texture like this. The wall it must be with paint, okay, or with ceramic all on the walls. And when we walk in the clinic where we put implants, we must not have comment on dit un tapis? No moquette, okay? Not like this. This is not good for a surgical place. It must be ceramic or it must be plastic. Never this. Okay, you understand? This is the minimum. And now, when we and now when we are going to put implants, the minimum is to have product we use only one time. Understand? It's a patch with all the trousers for only one time, and after it's finished. For every patient, it's not good to sterilize, to change a suite and so. No, always the same in a pack, closed. You open, you put, and after it's finished. This is a minimum when you put implants. And now we are going to see the 20 reasons for failure in implantology. Alors, if you have more than 1% of failure, it seems you do mistakes. And the first mistakes we do when we put implants is the powder of gloves. The powder of gloves, nowadays, in all around the world, it is forbidden when we are in contact with bone. In all the surgical places all around the world, if there is gloves with powder, talc or mice or what you want, it's forbidden. Because the powder of bone kills the bone. It kills the bone. Is the reason why when we put implant with gloves, we must take gloves sterilized and without powder. There is nowadays many gloves without powder, surgical gloves. Remember the reason, the most important of failure in implant, the powder of gloves. And the other reason of failure in implantology, a big reason, is the problem of periodontology. It's necessary to prepare the mouth, okay, complete mouth, so that it's clean without calcaire. Comment on dit ça? Without calcaire and without mobility of tooth. Without infection in the tooth, just near where we are going to put implants. And the element who help nowadays the most in our activity is the laser. Nowadays, with a laser, in one time, you do an anesthetic just 15 days before to put an implant. You do an anesthetic, you put oxygenate, comment on dit oxygenate? Oxygenous water, peroxide at 10% under the gingiva, and you pass those letters, and half an hour you do all half of the month, half an hour, and you sterilize completely the mouth, la bouche, mouth. Thank you. Alors, nowadays, the powder we know is forbidden. For periodontology, we know nowadays with the laser, it's very easy, very simple to prepare the mouth. And the tobacco, the problem of the tobacco. There is 10 years we say tobacco is not good for implantology. In reality, it's not a problem. But if they smoke more than 3 packs a day, there is difficulty for the gingiva to cicatrize, to have the cicatrization. It's when you put out a tooth, the last tooth, and if it smoke just before, there is osteoid. You understand? Is the reason why it's better don't smoke during 1 day before and 1 day after, and if they smoke less than 3 packs a day, you can put implant. But if they smoke more than 3 packs, you do the technique of Rafael Sarfati, is the endosteus stimulation. What is endosteus stimulation? The endosteus stimulation, you drill completely to put an implant, but you don't put the implant. He go out, he come back after 6 weeks, you open the gingiva, you pass the drill the same length but diameter under, and you screw his implant, and you have 100% of success. Okay? This is the endosteus stimulation. Alors, with tobacco, 90% you can do it, and 10% you do the endosteus stimulation. You have one question?
Diameter.
For example, you want to put an implant 1240, for example. You drill until 1240. The sequence complete, okay? He go out, goodbye. He come back after 6 weeks. You open the gingiva and you drill with the drill 1235. And you screw your implant and you have 100% of successful. This is a, pardon?
Why I made
this is the endosteus stimulation, because when you drill with 1240 and the blood comes in the hole, and after 6 weeks there is osteoblast, native osteoblast. And after when you drill 1233, 35, you have a fine osteoblast all around, and when you screw your implant, it is when it is a native bone, and you have 100% of successful. This is endosteus stimulation. You have another question? No, I continue. Alors, if you have a bone without blending, sometimes old people, there is not, it's D1, the bone is D1, there is not spongious bone. In this case, it's, if you put an implant directly, you have 100% of failure. If you do endosteus stimulation, you have 100% of successful. When you have not blood, when you drill and there is no blood, you drill and you wait 4 or 8, no, you wait 8 weeks. In the hole, it became osteoblast, they come osteoblast, and you do the same, you drill diameter down, the same length, and you screw your implant and you have 100% of successful. This is very interesting for all the people, and sometimes there is part of the mandibular when he don't want to accept the implant. You have one question, nothing? Okay, good. We continue. If you put an implant and you are in contact with the devitalized tooth, we fail through 50%, 50, 15? We fail 50% of implants if you are in contact with the devitalized tooth. Always. What we do, if you do an X-ray and you see you are in contact, you descrew the implant, you put the implant out, and you put another implant, and you drill different acts. Very important. But you don't recover the old implant. It is contaminated. And it proves this, that when people have a heart problem, and he have tooth devitalized, it's sure there is 50% of the tooth in the periodontic ligament there is bacteria. Is confirmation you see now when you do a correct devitalized tooth, you have bacteria in the ligament in 50% of the cases. And the doctor of the first have reason when they say we must put out all the tooth who have been devitalized. Is very important. Okay? So you fail. If you are in contact with a leaf tooth, what happens? Two solutions. You can have a contact with the apical part of the tooth. In this case, you cut perhaps the ligament, the vascularization. And if you cut the vascularization, it is necessary to control the vitality of the tooth just near. And if you have loosened the vitality, it's necessary to devitalize the tooth. If you don't do it, you fail your implant and you have an infection. And when you do a devitalized tooth, there is 50% of bacteria who come in the tooth, and you can fail the implant after. And this is a problem when you are in contact with the apex of a leaf tooth. Okay? Second possibility, you are in contact with the root of the tooth. You are in contact with the root of the tooth. In the X-ray, you say you have not cut the apex. But when you eat, it hurts the tooth, live tooth. You give contact, it hurts. No problem. In like orthodontics, the implant push the tooth, and after 3 weeks, it don't hurt, and the tooth is chilly. It's good. Okay? It's not a problem. Another reason important of failure of implant is the cleaning of the surgical box. When sometimes you use only one drill, you put one drill, why not? You do one drill, and the assistant clear only one drill, and she put in the box and she sterilize. It's not good. It's not good because they put all the instrument in the ultrasonic. When she put in the ultrasonic, when you put an implant and you return the box, they don't down. For example, the drill don't down. If they don't down, it significates there is silicone. If there is silicone, when she put all this in the ultrasonic box, and she pass with fresh water. Between the silicone and the port who come here, there is chemic product who are in the ultrasonic box. There is no the product chemic who are here. When you put in the contrangula and when there is water, it dissolves the chemic product who was in the ultrasonic box, and they go in the hole. And when you put your implant in the X-ray, very nice, all is correct, but when you put the healing cap, the implant comes. But what happened? There is not fibrosis, there is nothing. It's a osteointegration chimique. It comes from the product of ultrasonic. Is the reason why when they must clean, you use only one drill. She must put all the elements complete in the cap, special cap. She clear all the implant. She this without nothing in the ultrasonic, and you pass in fresh water. And after the element, there is an element, a click. Okay, you pass in peroxide, peroxide. Always this in peroxide, 30% of peroxide to put out the blood will go in. Okay, and after when you pass all in fresh water, you pass all the instrument is alcohol, 90%. Okay, and after all is clear, they put all the instrument without gloves, with powder, without gloves, with powder. She put on here, and you put in sterilization. Okay, this is a technique to clear a box. This is very important. And when you are problem, often when you change your assistant, when you have a new assistant, or when your assistant have a big family problem, it's a life, big family problem. She cannot do correctly the thing, and she hurry, she won't come house, and there is many problem. When you change an assistant, a new assistant, you have many failure of implant. When your assistant have many problem with the family, you have failure of implant. Take care. You must see what happened and heard what happened. The psychology of your assistant is very important. It's if you have, I do 3 interventions a day, sometime or 5. I cannot do all the important. You must control what happened exactly. Okay.
If you have failure, change your assistant.
Pardon?
If you have failure, change your assistant.
Or change the doctor. Because the assistant is a reflex of the doctor. Okay. Alors, instrument cleaning, okay. Sinus floor elevation. The sinus floor elevation always 3 or 4% of failure, always, because some person have limit. The nose, always the inflammation in the nose, and all the doctors, the nose can do nothing. Some people you can do nothing, and they forgot to say they have problem of nose, because they have when they young problem, old problem, always they have problem, and they forgot to say to you they have problem of nose. Okay, and you always have failure. The solution when you do elevation, floor elevation, is to begin is to put only graft, and if the graft is successful, you put implant, and now it's always successful. Okay, you begin in the beginning. In the beginning, you do this. Okay, but often if you have 6 millimeter of bone, always you can do, and it's hard the implant with 6 millimeter of bone is sufficient sometimes. Okay. Yeah. for other reason of failure in stabilized implant. If you do a mistake, you want to put an implant 4 millimeter, and you are excited, hurry, I don't know, you drill with a drill of 5 millimeter. The implant is moving. You cannot put implant. You fail. You stop. You wait 6 weeks or 7 weeks, and you like endoscopy simulation, and you put your implant. Okay? You must wait. You don't put your implant if you have a non-stabilized implant. But sometimes you can drill a little more, and if you use, for example, the implant of ideal with only 2 or 3 millimeter, when you drill, you can have a stabilization of this implant. This is a big difference between the ideal and all the other implants you find in the world. With the ideal, if you have only 3 millimeter, the point, it stops, and it never fails. The ideal is fantastic implant. Okay? Other reason of failure is when the doctor who come here during the REO, they have seen, during the training, they have seen just before we put an implant, we rinse the hole when we pass the drill. Why? You earn 1% of failure. Why? When you use water, sterilized water, to clear the drill, and you use the drill, the water go between the tooth. It turns, it go, it come, the aspiration, you put out the, no. But what happens? Between the tooth, always there is bacterial bud. Always. And sometimes, if you have a chronic problem of periodontitis, the bacteria go, sometimes it go in the hole. And if you screw the implant, you fail your implant. The solution, and always just before to put an implant, you have a syringe with serum physiologique and gentamicin near you. The needle, you put the needle like this, you put the needle in the contact with the fond of the hole, and the water put out all the things who are in the hole, and you earn 1% of failure. It is very important. Other reason of failure is the fibromucosis. Alors, this is very, it's not good for the dentist and for doctor, because he put implant, the X-ray, fantastic. He put the crown, fantastic. And 1 year after, the people come with the tooth, with the implant, and the crown in the hand. Doctor, your tooth, what happened? There is 3 months, it's very nice. There is 6 months, it's very nice. I don't understand. The reason, when you screw your implant, you screw one fiber of fibrosis, who are in the upper part of the bone. It's necessary to clear completely. If there is only one fibrous, when you screw your implant and there is only one fiber of fibrosis, after 1 year, she moved, she ground like an arbor all around the implant, and the implant comes directly with the crown. It's terrible for a dentist. It's an humiliation, comme on dit, une humiliation. It's an humiliation. You are a good doctor, it's very nice. Go, you can go house, you pay, you finish, and after you take your tooth and your implant. It's not psychologically it's very hard for dentists.
فهمتوا الجزء ده يا جماعة؟ الجزء ده مهم جدا، لأن كان بيتكلموا على الترانس جينجيفال، إن أنت ممكن تفتح فتحة صغيرة وتحط الإمبلانت بتاعك. انت لو مش منظف كويس حواليه ده بيحصل فيلر فعلا.
oui,
فاحسن تفتح بالنسبه للمبتدئ تفتح جراحه وتنظف كويس البون سيرفيس، ما تخليش اي ابيثيليوم وتحط الزرعه بتاعتك وتقفل احسن. لان لو انت مش خبير في الترانس جينجيفال انت اللي بتستخدم جينجيفال بانشر ممكن بقايا من الابيثيليوم ينزل معاك داون جروث في السكر يحصل لك مشكله كتير.
I forgot to put the transgingival when you put implant directly transgingival. You cannot put all the implant in transgingival. And when you want to put in transgingival, there is instrument when you begin to do a hole. You put out the hole, but there is fiber, and there is a little element who come to clear all around, to put all around the fiber. And after, it's very delicate to put an implant in transgigival, and you pay 30%.
Yes.
Take care. Is for dentists it's good, yes, fine. I no bone, I don't suture, but you pay many implants. Okay. Alors, transgingival, yes, very good. I am going to put transgingival. But it comes with fibromucosis. It's the same. Thank you for it. And post-extractive, I explain you. He asked me if I put an implant in a molar and sinus floor elevation and a post-extractive. I say you, if you don't want to have 30% of failure post-extractive, you must take a burr and racken all the bone in 0.5 millimeter or in the bone to put out the toxin who are in contact with the bone. It's a problem when you do a treatment of root. I explain you there is 50% there is toxin. Take care. It's the same problem with post-extractive. It's very delicate to do post-extractive. But you can do a thing very, very sympathetic. You put out the tooth. You drill. You wait 6 weeks. And you wait until the gingiva is closed. And after you put an implant, you can count the 6 weeks when you wait. It's the stimulation d'osseous in the time you want to wait. For example, you want to wait 4 months to put a crown. During the stimulation endosseous, stimulation, the 6 weeks, they go in the 4 months. You understand? Yes. This is the interest of the endosseous stimulation. Alors, it's better and less problem and less expensive and less work to put out the tooth, to drill. Goodbye. You come back after 5, 6, 7 weeks until the gingiva is closed, like an extraction. You open, you drill directly your implant. You know to do the crown after 4 months, and you count 6 or 7 weeks, and after to obtain the 4 months, and you successful completely. You understand? This, the endosseous stimulation is very fantastic, because the time you pass during this time is included in the time of the osteointegration. It's very nice, this technique. And it less, but if you want to do a good conference, you are a big doctor, you do the extraction, elevation of sinus, your put implant, is for your paper to do conference. You are a good doctor, but in reality, it's not medical good solution, okay? Alors, Helling cap that cannot be removed. Two problems. If you are in the front of the mouth, it's difficult to screw, and sometimes you screw not correctly the Helling cap or the cover screw. You are not in the axe, correct? And you block the screw. When you want to come back, it's very difficult to descrew. It's like if you screw not like this but like this, it's blocked, and the fillet is not good after. Okay, when you want to descrew, it's very hard, and sometimes if the implant is not big, it's not large, it's small, and you have the osseointegration is 4 months, for example. But when we say osseointegration for 4 months, for example, if for an implant of 15 mm diameter 4, it depends on the surface of contact with the bone. If you have an implant of 8 mm diameter 3.5, it's not to remember one thing. After 4 months, you have half of the surface of the implant is mineralized, half of the surface mineralized, but half of surface of 15 mm diameter 4 is not the same that 8 mm diameter 3.5. You understand? And the hand to descrew and screw is the same. It significates you have your mind take care. If you screw hardly the heading cap hardly with 15 Newton because you have a strong hand, when you want to descrew, sometimes implant come. Take care. You screw a heading cap delicately, 5 Newton, slowly with this. If it stop, you stop. Never like this. No, it's not good. Take care, okay? And you fail. You don't fail many implants. 1 implant in 1,000 implants. But why? You can do correctly, okay? I give you our experience in 25 years. And you do what you want. Okay. Immediate loading. The immediate loading is fantastic. We know the rule nowadays of immediate loading. There are international, I published this, there is 3 years. If you want to do an immediate loading, you must use an implant for immediate loading. An implant for immediate loading in IDI is the model. IDOL and IDBio and IDCAM. The IDMAC is not for immediate loading because the concept of the straight is different. You obtain a condensation lateral and a vertical condensation, and you have 3 unscrewing part in the external part of the screw of the implant. For the immediate loading, you must use a special implant for immediate loading. You must drill diameter under the diameter of the implant. For example, in the maxilla superior, you have 15 length of the implant is 15 mm, diameter 4. You drill with 15, back diameter 3.5. And when you screw hardly the implant, it is strong. Okay. And now, in this case, you do the impression the same day. And you put the ceramic crown 1 week after. This is immediate loading. This rule is minimum 15 mm, diameter 4. You drill with 15 mm, diameter 3.5. This is very important. Okay? And in the mandibular, you must drill the complete sequence. But if you want to do immediate loading, the complete sequence, you drill in the spongeus a small diameter of the drill, but in the cortical, you must cut the cortical, and you use the drill of 8 mm to cut the cortical, but in the down part is the spongeus diameter 2 mm. You understand? And when you screw the implant in the down part, the apex part of the implant, you strongly stop. Okay? This is immediate loading. The rule of immediate loading is 15 mm diameter 4 or 12 mm diameter 5 in the maxilla, and you drill 1 diameter under. This is the rule of immediate loading. And if you do this, always 100% of successful. In reality, we have found that there is 20% of the case we can do immediate loading. It's different that post-extractive loading. It's different. Post-extractive is different. Immediate loading is when the bone is cicatrized. Okay? Yeah.
So we will use the drill 3.5. Then we will put the implant 4.
Always, it's for immediate loading. For immediate loading, and the length 15.
The 4 drill we will not put it inside. We will not use.
No, never. For immediate loading, you have a compression lateral and vertical. Lateral, you drill 1 diameter under the diameter of the implant. Okay?
Yeah.
It's written in the catalog of IDI. It is written. Okay? Alors,
Bone heated up.
what is
Bone heated up. Heated.
C'est quoi bonne heated up? C'est ah oui, headed. Oh yes, yes. Headed up. Alors, bone headed up. Parce que c'est le truc qui me l'a traduit en anglais. Okay, bone headed up. It's when it's hot. It is hot in the bone. Two cases. Your drill is killed. And you want to economize. You don't want to pay a new drill, okay? And you always the same drill during 10 years. At the end, it's kaput. A man after 100 years, it's a drill after 3.
You cannot drill anything.
Okay. When the drill is kaput, you change.
If it's sharp drill, you can do many
The
elements in
most
one night.
important is the pilot drill. You change only the pilot drill. After 200 implants, you change the pilot drill. After 200 implants, but if you drill in the bone D1, after one drill, it's kill the drill. If the bone is D1, when I put implant in an old person, 90 years, is D1. And nobody wants to put implant because they have 8 millimeter. I can do it. It's easier. But she paid all the sequence of the drill. They are kill my drill. After one surgical act, in the end, the drill are killed. It's normal. It's hard. It's granite. Okay? You see, when the drill is don't cut, you change.
But then doctor to pay for them.
Pardon?
To pay.
No, it's free.
No, but when I do a price, when you do a price, if it's an old people, you know we are kill your drill, you put the price of the 5-second drill.
Oh.
Yes, it's the price of implant classic. In France is 1,000 euro for one implant classically, and the drill is 500 euro. For the drill, yes. She accepts. Okay, she don't accept. Goodbye. Go to another doctor.
Yes, you are right.
It's the technique. But we find this case one time until 3 years, 4 years, and old people. But it's not frequent. Alors, if the drill is kaput, it is dead. You change the drill. When you had the bone, if you want to use without irrigation at 2000 ppm, you burn the bone. If you want to use without irrigation, I have never used irrigation, never. But I drill at 100 ppm. Slowly, up, down, up, down. I put my drill in serum physiologique vision tamisé. I hold the bone down, I put, and up, down, slowly, delicately, like a new wife. Okay.
The rotation,
Okay.
how many the rotation of the drill?
Pardon?
100.
The rotation of the drill?
100 ppm.
100.
If I want to recover the bone, I go 100 ppm. There is bone who come all around my drill. And I have a cap with gentamicin and serum means physiology. I put my drill, tack, 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 the bone down, and I recover after the bone to do a graft.
So you use irrigation with irrigation?
And then, without irrigation.
No, the how many?
100 ppm without irrigation.
With irrigation.
And with irrigation, until, for example, no. Alors, I explain you. If you begin, you do always irrigation. If you begin, you always, because when you do irrigation, you rinse the whole. But okay, but if you after 1, 2, 400 implants, you can do it slowly without irrigation. It's evolution, but there is the ideal. The ideal is 2000 ppm with irrigation is one drill, one implant. Bzz, and it's finished. Okay? But with this drill, you cannot go at 2000. It don't cut the bone. This model of drill cuts the bone at 2000. This model, you must not cut the bone more than 350 with irrigation. It depends on the design of the drill. If you want to put IDBO, IDCAM, you drill with the surgical box for IDBO, IDCAM. In this surgical box, maximum 350 with irrigation. Okay? But if you go at 2000, you kill the bone. It's heated, it's burn out, it burns. Okay? But with the drill, 2000. And with irrigation is one drill, one implant. Here you must pass all the sequence. 1, 2, 3, 4. It's different. The design is different. Okay? Yeah. Alors,
Doctor, which technique is better, with irrigation or without?
I am an old doctor without irrigation.
الكارت موجود
If you
ومخبيه عندك.
begin with irrigation and after 1, 2, 3 years you drill without irrigation, when you want to recover bone to do a graft, you do without irrigation. But in the beginning, always irrigation to rinse the hole. It's very important. Pardon? Yes, 2000. What type? It cuts like this model is very fantastic. One drill, one implant. Yes. Pardon? 1,000. This is the plastic implant. This is the same.
The speed of the drill depends on the quality of the bone. You can make low speed for the drill or high speed, depending on the quality of the bone.
Depend of the drill. For example, this drill for ideal, the bone is hard on the head, is 2000.
We can use high.
No,
high
D1
speed.
you cannot. You cannot with D1. With D1 you pass first the pilot. If it's normal bones, you pass one drill, one implant.
It's not dependent on the quality of the bone.
Alors, if you want to use IDO, is a fantastic new implant, is a revolution. For me, it's a Ferrari. It's the best implant all around. It has 20 years advanced on all the implants all around the world. All around. But the Dr. Betage, he do a publication in USA, and he have 98% of successful. and it is one drill, one implant, and he do graft, and he do many things, because it's a single implant who in 3 millimeter it stabilized, and you can do many things. It's a fantastic implant, but it's more expensive than IDBO or IDCAM. But a doctor who had no problem of money for patient, he take immediately this implant, and for the life is shrinking, no problem. Okay, this is one thing. And if to help the bone is the drill is kaput, okay, if you turn at 2000 ppm without water, you kill the bone and you have no state. Okay, and every every model of implant, you must see the rule how to drill of every model. It's very important. Okay, maintenant, imbalanced occlusion. I failed 2 implants in my life, 2 implants, and I put 40,000 implants, 40,000 for whether in my life. Okay, and I failed 2 implants. Why? Because when I put the heading cap, I am a young doctor, very strong, and I don't control the occlusion. I don't control. And it go, and when it is implant, it seems nothing. It's like wood. You don't know you have an implant. And it come back 1 week after, and the implant is kaput. Why? And when I control the occlusion, the heading cap is in contact with antagonist. Always, before to say goodbye, you put a paper of occlusion, you control. If no problem, goodbye. If there is a contact, you take with a turbine, you regular the time. Okay. On fait quoi? Oui, mais en anglais. You control the occlusion, no contact with antagonist. Okay.
And also for immediate, for implant, if you will put static tooth or something, you have to check the occlusion also for anterior, not for healing cap only.
It's a very important question. If you have an anterior implant, anterior, aesthetic, if you cannot do the immediate loading because you cannot put 15 and 4, for example, you put 12, diameter 3.5, or diam 3. In this case, you put directly the abutment, and you put directly a crackery crown. In this case, take care, no contact, and take care you lose 1 or 2% of your implant, because with the tongue, il joue, comment on dit, he plays with the tongue and with the